and cultural extravaganza. ACIES is a cohort of healthcare professionals gathered for an exhilarating experience. In ancient Latin, ACIES means the thin edge of a ray of light, sharp and cross-cutting through the darkness. While according to the Romans, it is a battle line in a military formation synonymous with the word cohort. ACIES, the National Students' Public Health Conclave, is an ode to that cohort of brilliant minds in the field of healthcare who are studying, practicing, and advocating public health and healthcare administration across the country. ACIES has representations from academia, public health and hospital administration, students, and experts. It is the joint initiative that is envisaged by alumni, students, and faculty of eminent public health schools in India. The conclave will be graced by eminent healthcare professionals of national and international organizations working in the field of public health and healthcare in India and Southeast Asia, sharing their experiences and delivering keynote learnings on this year's themes for ACIES, which is transforming healthcare for a better tomorrow. ACIES provides a platform for young professionals to come together and create innovative solutions for crippling public health challenges in India. As we embark on the inaugural day of ACIES, let us commence by inviting our dear students to grace the stage with the divine energy of Ganesh Vandana, seeking blessings for an auspicious start to this event.
गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय वातापि गणपतिं भजेऽहं वातापि गणपतिं भजेऽहं वातापि गणपतिं भजेऽहं वातापि गणपतिं भजेऽहं वारणास्यं वरप्रदं श्रीवारणास्यं वरप्रदं श्रीवारणास्यं वरप्रदं श्रीवारणास्यं वरप्रदं श्रीवातापि गणपतिं भजेऽहम् हम वारणास्यं वरप्रदं श्रीवातापि गणपतिं भजे
Thank you for the exhilarating performance, dear students. With the resonating echoes of the Ganesh Vandana, let the blessings received pave the way for a harmonious and successful ACIES ahead. I now request our dignitaries to join the dais. Today we have with us Dr. Deepak Saxena, the Director of the Indian Institute of Public Health, Gandhinagar, Professor Dr. Sanjay Zodpe, the President of Public Health Foundation of India, Professor Dr. J.K. Satia, Senior Advisor, Public Health Foundation of India, and Emeritus Professor of IIPHG. Dr. Vikas Ben Desai, Public Health Expert and Technical Director at Urban Health and Climate Resilience Center, Surat. Dr. Bharti Kulkarni, Scientist G and Head of Reproductive and Child Health and Nutrition at Indian Council of Medical Research. And Dr. Anees Sinha, Registrar of the Indian Institute of Public Health, Gandhinagar. Thank you. We welcome you all. I now request our Director, Dr. Deepak Saxena, to welcome our Chief Guest for the day, Dr. Vikas Ben Desai. Thank you, sir. I request Dr. Somen Saha to welcome our ACIES orator for this year, Dr. Bharti Kulkarni. Thank you, sir. I request Dr. Anees Sinha to welcome Dr. Professor Sanjay Zodpe. To welcome Professor Dr. J.K. Satia. Thank you, sir. I would now like to invite Dr. Deepak Saxena to deliver the welcome address.
Very good morning to all of you. Respected Chief Guest Ma'am, Bharti Kulkarni Ma'am, Professor Sanjay Zodpe Sir, Professor Sakia Sir. It's a great pleasure for me to invite you on this sixth version of ACIES. I'm sure you all must be very eager and excited for these 3 days of conclave. The 2 days of this next 2 days we'll be having deliberation on the pre-lent session will have deliberation on transforming the healthcare, which is one of the most important agenda of this ACIES conclave also. In last 6 years edition, we have seen a transformation of the entire event. Before 6 years when we started with like-minded public health institutes, and today I'm happy to share that we have more than 300 odd registrations, and we are being represented by 5 public health universities across India. During these 3 days, the sessions that are being planned are very meticulously planned, and there are speakers who are from different parts of country. I'll only add a couple of achievements that IIPHG Gandhinagar has achieved in last 1 year or so. We have been designated as Center of Excellence for Collaborating Center of Excellence by ICMR. We have been in MOU with University of Nalanda, and Ministry of External Affairs has identified IIPHG Gandhinagar as one of the training centers for Southeast Asian countries. We have been fortunate enough to have been working very closely with government of Gujarat, other governments like government of Uttar Pradesh, government of Bihar. Our activities on heat action plan has expanded further. So I'll not take much time, but I welcome you all for this exciting deliberation for next 2.5 days. Thank you very much for joining us. Thanks.
Thank you, sir, for your insightful welcome address. I now invite Professor Dr. Sanjay Zodpe to address the gathering with his insightful experience.
Thank you, and very good morning to all of you. Distinguished dignitaries, we have a very eminent public health professional, Professor Vikas Ben Desai, as the chief guest of the program, Dr. Bharti Kulkarni, Professor Jay Satia, Professor Saxena, and Dr. Ani Sinha. Luminaries from the field of public health, invited guests, faculty, and students of our institution, but students who have traveled from other institutions and universities to participate in ACIES. It is indeed an extraordinary pleasure to welcome you all for this sixth version of ACIES, as mentioned by Dr. Saxena. ACIES provides the platform for a discourse in public health, which is critical in the context of our public health programs and for public health graduates. We as a country face several public health challenges. And as students of public health programs, you are aware of that, but still it is important to mention that although our life expectancy has reached to 71, but still if you look at the quality of life and if you compare our life expectancy indicator with other Southeast Asian countries, we are still the second lowest life expectancy in Southeast Asia. Our infant mortality rate, 27, 28 per 1,000 live births, but if you start comparing with our neighboring countries like Sri Lanka or maybe in Southeast Asia region with Thailand, the single-digit IMR, we have challenges. I come from Delhi, and air pollution, 1.6 million premature deaths every year are attributed to the air pollution. 1.2 million deaths are attributed to the tobacco every year. You take any random indicator and you would find that we are confronted with several public health challenges. And therefore, the role of public health professionals in ensuring that our populations are healthy and we contribute to the nation building is so critical and important. And we have a shortage of public health professionals in India. Association of Schools of Public Health in the United States a few years back estimated that they need 220 public health professionals per 100,000 population. I will pick up some random examples. The countries like Brazil tells us that they need 100 professionals per 100,000 population. But when we actually estimated more systematically the density of public health professionals, we have 11 public health professionals per 100,000 population. So we need more people to be trained in public health. Multidisciplinarity is the beauty of public health, because we draw upon the tools and techniques and principles and methods from a variety of the disciplines, from social sciences to statistics and nutrition to demography to other sciences, to contribute in enhancing the public health agenda. I would like to congratulate all of you for choosing to be part of the public health as a profession and deciding to be a public health professional, which is very important in advancing our national agenda also in the context of public health, but ensuring our societies are healthier. But keep in mind, a couple of things I wanted to mention is that science is sterile if it lacks the social relevance. And policies would crumble on cliff it if they are not firmly placed on a pedestal of valid science. Because when you talk about public health research, it's merely a tool. What ultimately benefits to the society is the knowledge. And therefore, when you talk about knowledge, it has two components, knowledge generation and knowledge translation. So keep in focus on eye that research is tool where we create the knowledge. But more important is that how do we actually translate that knowledge which benefits to the people of the country is more important. So always we should have in public health people to be at the center stage. Whatever we do in public health, we have to always remember that how it benefits to our own people. That's more important. And when I say that, you will have to think of two entities and keep in mind those, impact and equity. Whatever we do, how it is going to impact, how it is helping our people. So the impact is important. And of course, the equity is so critical and important. Randomly picking an example, and I today morning also spoke about it, a girl child which is born in Chhattisgarh or Madhya Pradesh or any northern Indian part of the country is 5 to 7 times more likely to die as compared to a girl child born in Kerala or Tamil Nadu. So in the lottery of life, it matters where are you born in India. These are the challenges of inequities that we face. So we always should keep as impact and equity as the hallmark of whatever work that we do in public health. In addition to that research, if in context of training and education is concerned, our institution, the focus is on transformative learning. That we believe that informative learning would help you to have knowledge and skills being built up. Formative learning a step further forward will help you to add ethics and values and morals. But more important is the transformative learning where we wanted to create the change agents and champions in public health who will really go into the field and transform public health. And that's the focus of our institutions that I wanted to mention. So keep always in mind that how you become a change agent to transform public health. And therefore, what is most critical in public health to work is passion and perseverance. Because public health is not something which can change everything overnight. You need to have a perseverance, consistent persistency, but with the passion that you need to work around. And the last point I wanted to mention is about the competencies. The technical competencies are so critical, like an epidemiologist, so epidemiological or management skills and competencies. You wanted to work in infectious diseases or non-communicable diseases. But you also spend time on building your professional competencies, which is so critical and important. How do you communicate? How do you articulate your thoughts, your writing skills, your scientific writing skills, the way you communicate, analytical skills, critical thinking, all these skills and competencies are important. So find time and invest systematically, strategically, and consciously efforts towards building on these skills, which are also equally important to make you a better professional. I'm sure These 2.5 days, and yesterday also some workshops were conducted here, would help you to advance the public health discourse, but also to gain some certain elements in the context of public health that you would like to carry back home and ponder on those issues. I wish ACIES all the best. Thank you so much.
Thank you, sir. It is now an honor to introduce our chief guest for today's inaugural, Dr. Vikasben Desai. Dr. Vikasben Desai is a public health expert and technical director at Urban Health and Climate Resilience Center, Surat. She is known for her work in public health, community nutrition, and reproductive and child health for more than 4 decades. She served as Additional Director of Family Welfare, Director of Reproductive and Child Health for 5 years at state level and has actively participated in community level training and advocacy processes. She is a member of the editorial board of the textbook on environmental epidemiology. She has several national and international publications to her credit and has designed and implemented various state level child health programs. She is also a founder secretary of Urban Health Society of India. It is indeed an honor to have you with us today, ma'am. I now invite Dr. Vikasben Desai to address the gathering.
Good morning, and it's always pleasure to be here and to be with the future experts of public health. It's also a pleasure to be a supari instead of coconut. That's what is Gujarati said, replacing somebody, or somebody is absent and you are taking over the responsibility. Whenever I am introduced, I am getting to understand myself better. So thanks for my introduction also. Very happy to meet you all. Few things which I would like to highlight for public health, not in very lucrative language as Dr. Jodpe has done, because I have learned ABCD from 8th standard, so I have limited vocabulary. Anyway, and I am not ashamed of it. I am proud of it. And if you all agree, I can speak in Gujarati or Hindi also. Okay. And I love to do that. I am very happy that Gujarat was first to introduce public health cadre in health services. And I remember I went to Jaipur to recruit the first batch in Gujarat Health Services. And it's long time. I'm also happy that 2008 was the year when the foundation of this institute was laid, when I was here as a director. And today the second foundation is also going on. Happier because my student is director now. And I used to call that as the satellites of my department, and this has come true. He is one of the bright satellite of my department. Even Anish is my satellite. And this is something which is worth learning. I don't say my previous department, it's my department. So for all of you, this is a learning. The institute which you try to strengthen is your institute for lifelong. I have few advisory words for you people also. It's good to write papers. It's good to be in good position in good institutions, but it's always good to understand public health. Public health cannot be learned and understood in short time, cannot be learned and understood through Google, through textbooks, through classrooms. Public health is to be learned and understood in public. And you learn every day new things. Even I am learning today. I don't claim to be the expert in public health. I am a learner in public health. And I am currently working on child-friendly city. I am learning from children what are their suggestions for air quality, what are their suggestions for sanitation, for environment, for climate change, and even education and health services. So you learn daily. And when you learn public health, you can't say, I'm in nutrition project, so I will think about nutrition or I will look at the nutrition. You come across so many things when you work in field which you have to link up with nutrition. And as I have uttered a word nutrition, I tell you, nutrition is not a separate subject. Nutrition is health. Sanitation is health. Public health is all together. But then we should have enough courage to say that everything cannot be done by health. Because the contributors are several to the cause, to the outcome, and all departments are responsible for it. So if you take only as your responsibility, you take more blames than any solution. Another important learning in public health is, don't go on grumbling that cardiologists have took over, pediatricians have took over, specialists have took over. Once they have 10 years of practice, they are little free, and everyone likes to be the community person, because that is more satisfying. So they start indulging into it. And for the heads, administrators, and policy makers, public health people are not doctors. Doctors are cardiologists, oncologists, respiratory specialists, renal specialists. They are the doctors. So they are the better advisor for them. So learn to work with them and contribute in a way that your contribution is a specialized contribution. Then it works. So it's very difficult to define public health. You do the work and you learn about public health. You meet with the experts and you learn about public health. You meet with the experienced people and you learn about public health. But I remember the sentence which is written in the quotation, you should be prepared for most insulting, presumptuous judgment of ignorance. So don't worry about it. You do your job and you will find out a way someday. So that is public health. You all have come from different streams, maybe health, maybe medicine, maybe alternative medicine, maybe dentistry, maybe sociology, statistics, and so on. It's easy to work on computer, compile the data. I'm purposefully, maybe my experience is outdated with the first 2-3 batch which we recruited. But you may be very good in all this, working on in office for public health, but it will not give you insight of what is happening in the field. And you should have that courage and enthusiasm to do innovations in public health. Say, this slogan, what was that? For better future. Future is built up on the past. So you need to understand past and build up on better future. And then ultimately what you do is little innovation in the strategy. Otherwise things are same. Say for example, I was just discussing in the office, if you have to control malaria, you kill parasites and you kill mosquito, that's all. Now how to do that goes on changing over a period of time. How to do that changes over in the geography. How to do that changes with the experts. But ultimately your goal is to kill both of them so that there is no health problem. So the same thing applies to almost all aspects. Even in nutrition now we are talking about Ayush, which is again revival of what our ancestors had learned or taught us, the traditional practices. You change the names, but it is same. Now, the challenge is to prove it scientifically, because we are all scientists and we need a proof and evidence-based planning, but do it, don't ignore it, and that's where the beauty lies. So I wish you all the success for ACIES, and I hope your contributions and your participation will add to the strength of public health in Gujarat. Thank you.
I extend sincere gratitude to our esteemed chief guest, Dr. Vikasben Desai. Thank you for gracing this occasion with your valuable perspective. Moving ahead, I have some exciting news for all members of IIPHG. I am honored to present that this year IIPHG has embarked upon a new journey which will benefit all healthcare professionals. A journey that not only lets us hear the stories of aspirants, but also one that teaches us from their stories. Presenting to you the podcast by the Indian Institute of Public Health, Gandhinagar, Swasthya Vani. I request and invite our chief guest for today, Dr. Vikasben Desai, for ribbon cutting to launch the podcast. I also request Professor Dr. Sanjay Dodpe to launch the digital version of the podcast. Thank you so much. The first season of this podcast has been recorded to showcase the journey of choosing public health as a postgraduate degree by our first year MPH students, and each episode will be released on Sunday. Stay tuned to contribute to Swasthya Vani, IIPHG's own podcast channel. Let us now begin with the ACIES oration program. It is with immense pleasure that I call upon Dr. Anees Sinha to introduce the ACIES orator of this year, Dr. Bharti Kulkarni.
Respected dignitaries on the dais, off the dais, dear faculty members, and my dear students and delegates. Our ACIES orator for the year 2023 is Dr. Bharti Kulkarni, who currently serves as a Scientist G and head of the Division of Reproductive Biology, Maternal and Child Health and Nutrition at the Indian Council of Medical Research, New Delhi. She has completed her MBBS from the University of Pune, where she also pursued her postgraduate diploma in child health. She then pursued Master of Public Health from Johns Hopkins Bloomberg School of Public Health, USA, and PhD from Queensland University of Technology, Australia. She has also held the position of scientist at ICMR National Institute of Nutrition a premier institute in nutrition in Hyderabad from 2000 to 2021, where she served as the head of the clinical division from 2017 to 21. She has received prestigious awards and fellowships. To name a few, was Joint Japan World Bank Graduate Scholarship Award in 2007, the Global Health Research Scholarship from Johns Hopkins Bloomberg School of Public Health, and Dr. P.G. Tulpule Oration Award in 2021. Madam is also a fellow of the National Academy of Medical Sciences. Dr. Bharti's research interests are maternal and child nutrition, including anemia, developmental origins of health and disease, and body composition. She has also researched in agriculture, where she worked on nutrition linkages and community-based interventions to promote diet diversity. Regarding grants, she has received many of the grants. To name a few, she received UK RIGCRF Action Against Stunting Hub, funded by the UK Research and Innovation, received grants from Bill and Melinda Gates Foundation, UK Aid, USAID, DBT, and many more. She was also the principal investigator of a task force appointed to study anemia funded by the ICMR. Over 100 peer-reviewed publications in high-impact journals are under her credit, and she has also contributed book chapters and policy documents in many of the books. Dr. Bharti has also organized several international meetings, including the Indo-UK workshops in Agriculture, Nutrition, and Health Academy. She has also organized a year-long series of maternal nutrition technical e-dialogues along with the Federation of Obstetrics and Gynecological Society of India. Dr. Bharti has also released articles in newspapers and magazines on issues related to nutrition, given numerous lectures on maternal nutrition, healthy diets, and bone health. She also contributed in educational programs organized by the UGC Knowledge Network. When we tried to compile Madam's the overall journey of the academic and the public health contribution to nutrition, it went into pages. When we decided we are not going to write a book at the moment, and hence we tried to curtail to the brief introduction. And with this, these were the few glimpses of her journey, and it's indeed an honor to have you as the ACIES orator, ma'am. Thank you. Over to you, ma'am.
Is it working? Good morning, everyone. Very delighted to see young faces in front of me. It's indeed an honor and privilege to be here in front of you, and I'm very, very grateful to IIPHG Director, Professor Deepak Saxena, Dr. Somin Saha, all the dignitaries on the dais for this honor. Can I have...
You can change it directly from the pointer.
But I need to see.
It's not loading. You can see it over there. नहीं सर इसमें है नहीं loading.
अच्छा ठीक है, I have to. I can see. I can see it there. Okay, that's fine. It's okay, I can see on the screen. So, no, it's all right. हाँ. This pointer is useful. Thank you. I thought I'll take this opportunity to share my research journey and also my transition from being a clinician taking care of patients to a public health person. And you, as budding professionals, may take some insights from me, which will be, I hope, will be useful. So, as a pediatrician, it was very, very obvious that there is social patterning of childhood diseases. You can, like as Professor Zodpe has mentioned, that a girl born in a southern state has much higher probability of living, and you see that in everyday practice. You see that children dying from simple to treat diseases such as diarrhea when they come from rural areas, and you see that children from more privileged background survive more intractable diseases. So this was quite obvious, and also we had a lot of unanswered questions where we don't really have Indian evidence, and that becomes a lot of limiting step for us. And many of our doctors have devised their own thoughts and treatment modalities many a times, but which are not scientifically tested and not really documented. So a lot of knowledge lies within people, which is not really useful to others. And I thought I got an opportunity to work in a research institute, National Institute of Nutrition. And I was very excited to take it up because it offered a continuous learning opportunity. So I think that is a real motivation that in research you are a lifelong student. And I think apart from gaining knowledge, you are also generating knowledge, which is a very, very powerful thing. Also, there is an opportunity for contributing to policy and program design, and therefore you are able to impact on a much larger scale, and that is a real motivation. So coming to the topic of undernutrition, which has been the main research agenda of the Indian research agencies, although it is shifting now to also overnutrition and non-communicable diseases. We all know that our country has made rapid strides on economic progress, but we are still grappling, on the other hand, with the issue of undernutrition. When we look at our National Family Health Survey data, in case of under 5 children, we see that some progress has happened. For example, stunting prevalence reduced from 48% in the third round of National Family Health Survey, which was in 2005 to 6, to 38% after 10 years. And it has not changed much since then. Oh, sorry. And although this progress is there, it doesn't really go well with India trying to become an economic superpower, but at the same time, more than a third of the children being stunted and undernourished. And although we have made progress on reducing undernutrition, on the background of rapid economic progress, this is not in sync with that. For example, between the decade of 2005 to 2015, the mean height for age Z-score, which indicates reduction in stunting, improved by less than half standard deviation. But during this same period, the World Bank estimate was that the real per capita GDP of the country doubled. So we expect that undernutrition will reduce as a byproduct of economic progress, but that's not happening, and it means that it requires concentrated efforts. While we are struggling to reduce undernutrition, there is also a concomitant increase in overnutrition, and therefore it becomes very difficult for the policies to tackle the two extreme forms of malnutrition simultaneously. And we need policies that can reduce undernutrition without increasing overnutrition, and that's a real challenge India is currently struggling with. So we can see that even in the rural areas, overnutrition prevalence doubled over subsequent rounds of National Family Health Survey. And what is more worrying is that the prevalence of overweight in children is also rising rapidly. And when we look at the comprehensive National Nutrition Survey data, we can see that almost 5% of children which were under 5 years of age had overweight. And this increases as children grow to become adolescents and adults. Another worrying finding of the Comprehensive National Nutrition Survey was that in case of adolescents who were in the age group of 10 to 19 years, in many states, more than 20% of the adolescents had higher fasting plasma glucose. So it just means that even at a young age, there is impaired glucose tolerance. We can expect that we are going to face a larger burden of NCDs in the coming years. We also have another challenge, which is perplexing, that the prevalence of anemia in under 5 children, adolescents, women of reproductive age, pregnant women is not reducing over years as we would expect. There is also evidence that Indians tend to have non-communicable diseases in the absence of frank obesity, which is measured by body mass index. And a number of studies have shown that Indians tend to have a body composition with higher fat mass. So we may not look obese when we measure our weight and height and calculate body mass index, but we have higher body fat percent as compared to other population groups, which increases the risk of non-communicable diseases in us. And there are studies from Pune and other places that even neonates born in India had higher body fat. So this is an intergenerational problem. So we all know that in spite of having lower body mass index, South Asians, including Indians, have more abdominal fat, more insulin resistance and hyperinsulinemia, higher levels of C-reactive protein, which indicates ongoing inflammation, and also increased susceptibility to type 2 diabetes and coronary artery disease. So WHO has recommended not exactly a cutoff, but action point at a BMI level lower than what is considered as obesity and overweight in the global context. While we were doing studies on bone health in women, we found that women who had a lower BMI had much higher risk of osteoporosis and hip fractures. So this raises a complex situation that women with lower BMI and body fat, lower body mass index had higher risk of fractures, and women who had better body weights and higher BMI were protected from fractures. So this raises a complex situation that higher body weight and body mass index increases the risk of metabolic syndrome, increases the risk of non-communicable diseases, but it has some protective effect in terms of reduced osteoporosis and reduced risk of fractures, which are also a debilitating condition. So we need a solution where, like, we cannot increase the risk of one disease to reduce the risk of another disease. And when we tease apart what is the driving factor it comes out that when the body weight is contributed by fat mass, more fat mass, it increases the cardiometabolic risk. Whereas when the body weight is higher because of higher muscle mass, it has a lot of protective effect in terms of increasing fitness, improved immunity, and reduced morbidity, and that is coming out quite clearly in many of the research studies we conducted. We had a study in urban slum of Hyderabad where we analyzed the body composition data of women who were involved in manual occupations. And what we found that they had high body fat percent, that is more than 30% of their weight contributed by body fat, at a body mass index of 20, which nobody considers as overweight or obesity. And at the BMI of 22, they had more than 35% of fat. So it just means that in our population, the body fat percent and BMI relationship is very steep. And we cannot ask people to lose weight, because otherwise, if they become undernourished, when the BMI falls below 18.5, which is considered as undernutrition, it increases number of risks, including reduced work productivity. In case of women, when the women are undernourished, it increases the risk of having low birth weight babies. So we cannot really ask people to reduce weight in order to attain lower body fat percent. What we need is reducing the slope of this line. And this will happen only when we have higher muscle mass. And this was quite evident in the data which we analyzed. When we grouped these women in groups of body mass index, higher the body mass index, higher the body fat. But when we grouped these women in tertiles of height, we can see that they had higher weight. Those who were taller had higher weight, but they did not have higher body fat percent. So it means that if we have interventions to reduce childhood stunting and have optimal growth in adulthood, it is probably one of the ways to reduce the double burden of malnutrition. We have a very severe problem of maternal undernutrition, maternal anemia. When mothers are undernourished, they give birth to babies who are low birth weight. Low birth weight babies tend to grow as stunted children, and when the stunted children become adults, they have altered body composition, they have lower muscle mass, higher body fat, and because of that, they have impaired fat oxidation, they have reduced resting energy expenditure, low muscle mass is linked with poor physical activity, and all these contribute to increased risk of non-communicable diseases. There is a role of developmental programming which happens intergenerationally, but it is also contributed by various risks which a person accumulates throughout their life course. And major diet, suboptimal diets, unhealthy diets is a major contributor. We have low intake of milk, as our data shows, and also other foods which are good sources of protein, zinc, calcium are lacking in Indian diet. Vitamin D deficiency is highly prevalent. We have, earlier it was considered as a paradox that in a sunny country we have high prevalence of vitamin D deficiency. But if we think ourselves, how many of us expose ourselves to sun? We come in the morning to classes or office and we leave in the evening. And sun exposure, which is crucial for vitamin D in the noon, closer to noon hours, we don't expose ourselves. So it's, in a way, it's not surprising that we have high prevalence of vitamin D deficiency, and it's also one of the contributors to increased prevalence of non-communicable diseases. There is a lot of focus of the Poshan program of the government on reducing childhood stunting, because it's not that just low height matters. It's not that just we are concerned about low height. The stunting is a big issue and big concern for the government, because children who are stunted are also tend to have higher risk of cognitive deficit. And it may or may not be causal, it's still debatable, but the children who grow in a poorer environment, which leads to stunting, also leads to impaired cognition. And we as India becomes a knowledge-based economy, it is very, very important to have cognition as a focus. There was a review on the task content of jobs in India. It is very clear that there will be less and less opportunities in occupations which require manual effort. But there is more potential for jobs in manufacturing and services and occupations which require higher cognitive competence, but we don't have enough people with those skills. So it's important that cognition is also considered as an important outcome in many of our endeavors. So we have global nutrition targets, and one of them is to achieve 40% reduction in the number of under 5 children who are stunted. And India has an explicit aim of reducing stunting by at least 2% per annum. But how to achieve that is a big question mark, because many of our studies where interventions were given to improve complementary feeding or giving different micronutrients have shown very, very modest impact. So we really don't have an answer, but then the recent data is showing that we require integrated interventions. It's not just giving food supplement will help, but we require better hygiene, sanitation, we require care of women starting even before pregnancy and continued throughout pregnancy to make that happen. And because of that, this focus on reducing childhood stunting globally and also specifically in India, there is a large research study ongoing currently at National Institute of Nutrition as well as IIPHG Gandhinagar. It's a multi-country study in 3 countries. It's called Action Against Stunting. And this study is being done currently in India, Indonesia, and Senegal, where there are different patterns of stunting and wasting. And the main aim of this study is to gain deeper understanding on the determinants of stunting through interdisciplinary investigation. Interdisciplinary is critical. One discipline cannot solve nutritional problems. Nutritional problems are beyond nutrition because they encompass interdisciplinary issues. And another aim is to evaluate interventions to reduce childhood stunting. And there are 17 partner institutions involving 8 disciplines, including biology, clinical medicine, psychology, because we need to understand how people will accept interventions, how behavior change is so critical for improving health of the people. So we require people from veterinary medicine, nutrition, economics, anthropology. So I cannot emphasize enough on the need for interdisciplinary approach and having different disciplines work together to solve an intractable problem. So currently there is a cohort of 500 pregnant women which is being followed right from pregnancy till 24 months of age. And there is intense data collection, including anthropometry, diets, epigenetic, gut health. Food is, we traditionally tend to just inquire about the food intake, but we have to see the larger context about the access, affordability, acceptability, and food safety. All these are critical issues. Cognition, as I mentioned, is an important indicator which we need to focus on in terms of overall development. So there is, I will not go into details, it's just that I wanted to highlight that when you are looking at a problem which is not being solved easily, you need an interdisciplinary approach. So here we hope to identify critical interdisciplinary pathways leading to stunting. We hope that this study will enhance knowledge on typology of stunting. There will be increased awareness of improved stunting, improved nutrition, and learning environments. And we hope that this study will generate novel resources and data for researchers. And ultimately, as Professor Zodpe said, that people should be at the center. It should benefit the community. Otherwise, it's fascinating research. It will lead to research publications. It will benefit researchers. But what about the community, which is at the center stage? So ultimate aim should be to reduce stunting and also reducing the impact of stunting. The children who are already stunted, how can we improve their cognition? Because there is still plasticity, and cognition also depends on the learning environment. How can we improve learning environment for children to improve their cognition? What kind of job aids we can create so that, because the Anganwadi worker has a lot of tasks. Nutrition supplement, providing nutrition supplement is one task, but also important is informal education, but that has been neglected. How can we create job aids for Anganwadi workers so that she can provide a stimulating environment? So these are some of the issues which this study is handling, and I wanted to let you know that there are these kind of opportunities in public health research where interdisciplinarity is the key. Coming to another intractable issue of anemia, this has been a big concern for the government, that anemia prevalence in different age groups is not reducing. And when we look at the background of anemia control program, we can see that because of concentrated efforts government has put in the program of Anemia Mukt Bharat, we see that program has strengthened. For example, women who consumed iron folate tablet, if we look at the NFHS data, it has increased. But still, we are not seeing a concomitant reduction in anemia. We have a target of reducing anemia by 3% per annum in women and children. And the Anemia Mukt Bharat strategy has 6 beneficiary groups, 6 interventions, 6 institutional mechanisms. One of them is point of care testing and treatment of anemia, because we have 50% people who have anemia, but they don't know they have anemia. They don't know that they have to take treatment. So unless we identify people and treat them, we are not going to see a remarkable success. So our group worked on a point of care method for screening of anemia, which will be precise and accurate. And we have used a pooled capillary blood sample coupled with a small autoanalyzer, which is made mobile by keeping in a van. And we have done this estimation in more than 15,000 people by now. And we have shown that this method is very accurate and precise as compared to the gold standard method. So high prevalence of anemia, despite strengthening of the anemia control program, remains a perplexing challenge for the country. There are issues related to IFA supply, iron folate supply related problems are there. Many times supply is not there, and therefore people don't get the supplements. There is also a big issue of poor compliance to supplement. And poor compliance to supplement has been one of the biggest hurdles. One needs to understand how to improve compliance, or otherwise what are the other ways in which to reduce anemia. So we all know that anemia is a multifactorial etiology. Iron deficiency is one of the causes, but there are multiple other causes, but our programs are currently revolving only around one cause, that is iron folate. And but we really don't have the data on iron deficiency, because population surveys usually measure only hemoglobin, and it is used as a proxy for iron status. And we need population estimates of iron deficiency, but these are high cost and technically challenging, so we have really limited data. But the recent comprehensive National Nutrition Survey, led by the Ministry of Health and Family Welfare, has provided this data in children from 1 to 19 years of age, and this is one of the largest micronutrient surveys in the world, where we have data on more than 50,000 blood samples. And we analyzed, our group analyzed the data on iron deficiency, and we found that prevalence of iron deficiency in all age groups was lower than that of anemia. We all study in biology that iron deficiency initially leads to depletion of iron stores, and when it is extreme, it leads to anemia. So we should expect that anemia would be a will have lower prevalence than iron deficiency, but we don't see that. So it means that there are other causes of anemia which we are not currently targeting, and that remains a focus of inquiry for our research group as well as many other research groups. When we look at the state level differences in prevalence of anemia and iron deficiency, we expect a similar pattern if iron deficiency is the major cause, but we don't see that. We have arranged the states in the rank order of their per capita GDP, and we expected that poorer states will have higher prevalence of iron deficiency because the diets are a reason, but we don't see that in case of iron deficiency, although we see that in terms of anemia to some extent. We also saw some very confusing trends, that when we looked at the prevalence of anemia in relation to the wealth quintiles, we see a trend which we can expect, that poorest of the people will have higher anemia. But when we look at prevalence of iron deficiency in relation to wealth quintiles, we see the opposite trend, that the richest quintile children have highest iron deficiency. So it's not really a very simple picture, and it's very complex. And when we analyze this data, what we saw that there was a gradient in terms of serum ferritin and hemoglobin, which indicated that for higher income group, there is better utilization of iron for making hemoglobin because of better hygiene, probably because of other nutrients, because of better quality diets. These are some of the conjectures. This is what we are hypothesizing, but there are studies which have shown that in case of even the African Americans, they have lower iron deficiency but higher anemia. We are seeing similar picture here. So we think that there is a problem of inefficient utilization of stored iron for hemoglobin synthesis because of higher infections in the low-income group, which leads to inflammation. There is overall diets are of poor quality. There is low intake of high-quality protein. Hemoglobin is not just heme, it's also globin, which is a protein. So we require higher quality protein and other nutrients for hemoglobin synthesis. So we think that there is probably a functional iron deficiency. The iron from the diet is not completely utilized, and therefore iron supplementation alone may be of limited value. We require integrated, multifactorial, interdisciplinary investigation, and also solution has to be an integrated intervention focusing on healthcare, focusing on improving wash and sanitation, reducing infections, improving diets, and also iron supplementation. Then probably we will have a better impact. When we look at the data from dietary intake of iron from in different states and their prevalence of anemia, we can see that in this graph that Kerala and Tamil Nadu, they have lower intake of iron, but they have better health indicators, they have better lower prevalence of anemia, whereas Madhya Pradesh and Gujarat, if you see the dietary iron intake, it is higher, but the anemia is also higher. So it's not really going hand in hand, and we require deeper inquiry into these issues because these are complex problems, otherwise we would have solved it years ago. We also believe that there is probably a role of body composition. Indians have lower muscle mass and therefore low basal metabolic rate. So is our hemoglobin requirement lower? I think there are studies which are currently ongoing to identify a functional cutoff of anemia. Currently, we use hemoglobin cutoff by WHO, which is based on Western population, and few studies done in 1960s. So we need newer information, newer data to guide our policies. We also need interventions which are for improving muscle mass and body composition, which looks like a crux of the solution for tackling double burden of malnutrition. It requires improvement in birth weight. It requires optimal childhood and adolescent growth. All these require diet diversification, improvement in water, sanitation, hygiene, better access to health care, more physical activity. We should not dissociate physical activity from nutrition. Physical activity is critical for improving our improving health and reducing non-communicable diseases. But in today's world, which is very competitive, and children have no time for physical activity or space, I think this is becoming a neglected area, and that's a big concern for non-communicable diseases. Sun exposure, I think it's a simple measure to reduce vitamin D deficiency, and we have more than 80% prevalence of vitamin D deficiency. So these are some of the issues where we need focus, and public health students and researchers have big role to play in promoting health in the coming years. When we talk of nutrition, we see that suboptimal diets with low intake of foods which are high quality underlie maternal undernutrition and anemia, underlie childhood undernutrition and anemia. These suboptimal diets contribute to high fat and low muscle mass body composition, leading to non-communicable diseases. But again, these are interlinked with availability, food availability, food affordability. What if in India we are a superpower in terms of milk production, in terms of production of various other agricultural commodities, but it is inequitably distributed. The prices are not affordable in rural areas which produce milk. So where it is produced, it's not available for consumption by children. So access to food, all these are important, and agriculture has a very crucial role. Till now, agriculture is seen as like occupation for livelihoods and for income, but there is also increasing awareness that it has to be nutrition sensitive, and the government is thinking in this direction. Also, our dietary habits are not knowledge-based. It's cultural, culture and belief, and these are ingrained over generations. It takes time to change dietary habits, and also desirability. We desire foods which are considered, which are advertised, which are considered like desirable based on celebrities. I think all these factors play a role, and changing dietary habits is very difficult thing, and it requires a food systems approach, and again interdisciplinary approach. So WHO has published this policy brief on double duty actions for nutrition. I would urge all of you to go through it, because this is going to be the key issue, double or triple burden. If we considered micronutrient malnutrition, overnutrition and undernutrition, it becomes really double or triple burden. So we require interventions and programs and policies that have potential to simultaneously reduce the risk of both undernutrition, which includes wasting, stunting, and micronutrient deficiencies, as well as overweight, obesity, or diet-related non-communicable diseases. And we also need focus also on interventions that promote muscle mass, which requires locally available nutrient-dense foods, and promoting physical activity, especially outdoor physical activity and sun exposure. So I just wanted to give you a brief idea about ongoing research efforts in this area on some of the intractable problems. So coming to what I learned from this experience is that complex problems require interdisciplinary efforts. I cannot emphasize this enough. And public health nutrition needs involvement of professionals from different backgrounds. For example, anemia cannot be solved by just physicians. It requires behavioral experts, it requires biologists, it requires health system people, it requires economists for planning our supply. So it requires involvement of professionals from different backgrounds. Collaborations are crucial because one cannot just do this on your own, and I think beauty of public health is a teamwork. You get to interact with a lot of people, you get to learn from each other, it enriches you as a person, and it broadens your horizon. And solutions to nutrition problem require a broad-based approach. It cannot be, there is no magic bullet or silver bullet to solve an issue. You require a broad-based approach with nutrition-sensitive as well as nutrition-specific solution. Also, I would like to tell you that the progress is slow. We sometimes feel really disheartened. We are working so hard, but we are not seeing the fruits. I think it requires patience. The solutions will come very, very gradually. And we have to have vigilance to ensure that solutions to one problem do not result in newer problems. Like if we aggressively treat undernutrition, we have to make sure that it does not go to the other extreme. So we have to be really vigilant. But I think it is a really enriching journey, and it is really an exciting field. I'm sure you are all looking forward to it. I would like to acknowledge all this research effort. For that, support from ICMR and ICMR National Institute of Nutrition leadership over the years. My colleagues who have been, we work as a team, and you cannot achieve anything individually. It's all team effort. Collaborators, especially the Action Against Stunting Hub led by Professor Claire Haffanan. For the Comprehensive National Nutrition Survey data, collaborators, Dr. Kurpad and Dr. Sachdev. PhD students, we learn a lot of things from students, and project research staff, and finally, family, which is a strong pillar of support for all of us. And with this, I thank you for your patience. Thank you.
Thank you, ma'am, for the insightful ACIES oration. I think we have definitely got many points to ponder upon and take insights from your learning forward. I now request Professor Dr. Sanjay Zodpe to felicitate Dr. Bharti Kulkarni. Thank you, sir. I now take this opportunity to welcome our dignitaries of the dais. Dr. Brian Wall from Johns Hopkins University, Dr. K.D. Rao, Dr. K.D. Rao from Johns Hopkins University, Dr. Raj Shankar Ghosh, Advisor on Environmental Health for Public Health Foundation of India, Dr. Som Shekhar Nimbalkar, Professor and Head, Department of Pediatrics and Dr. Sandeep Patel, Founder and CEO of DocHub. Thank you. With this, we now come to an end of the inauguration program. I thank the dignitaries on the dais for gracing the occasion with their presence. I request all dignitaries to take their seats off the dais. Can we have a round of applause, please? Thank you. I now request Bilal Hassan and Ashlesha Mishra to join the stage and begin with the first panel discussion.
Good morning and a warm welcome to the first panel discussion of ACIES, centered around nutrition, evidence, programs, challenges and solutions. I am Bilal.
And I'm Aslesha, honored to be a host for the significant session powered by Naira Energy.
The discussion on these crucial topics that affects us all over the course of our time together. We will dwell into deep depths of nutritional understanding, exchange insights and existing programs, tackle challenges head-on and seek innovative solutions.
Welcome to a gathering where knowledge meets action in the realm of nutrition. Today, we gather with a distinguished lineup of speakers and experts.
Without further delay, allow us to introduce our esteemed chair for this session, Dr. Vinod Rao. Dr. Rao is a Gujarat cadre IAS officer of 2000 batch. He currently serves as Secretary, Primary and Secondary Education, Government of Gujarat. He has previously served as Mission Director, National Health Program in Government of Gujarat. He has received the Prime Minister's Award for Technology-Driven Transformation of School Education System in Gujarat through Vidya Samiksha Kendra under the category of Innovation States in 2022, and also received Best District Development Officer in 2006. He holds a MA degree in English Literature, a Diploma in Journalism, and PhD in Management. We welcome you on stage, sir.
Joining Dr. Rao as our co-chair is Dr. Bharati Kulkarni. It is with great honor and distinction that we welcome Dr. Bharati Kulkarni. Dr. Bharati Kulkarni is currently serving as Scientist G and Head of Division of Reproductive Biology, Maternal and Child Health and Nutrition at the Indian Council of Medical Research in New Delhi. She has also held the position of scientist at ICMR NI in Hyderabad from 2000 to 2021, where she served as the head of the clinical division from 2017 to 2021. Dr. Kulkarni has received prestigious awards and fellowships, including the Joint Japan World Bank Graduate Scholarship Award in 2007 and the Dr. P.G. Tulpule Oration Award in 2021. She is also a fellow of the National Academy of Medical Sciences. Dr. Kulkarni has secured significant research funding, including a GBP 19.7 million grant for the UKRI GCRF Action Against Stunting Hub. We heartily welcome you on stage, ma'am.
Stirring our discourse is our moderator, Professor J. Sathya. Professor Sathya is our senior advisor to the President of Public Health Foundation of India. Professor Sathya is Professor Emeritus at IIPHG and he was our former director. He is professor at Indian Institute of Management, Ahmedabad for more than 20 years and has served as dean during 1987 and 89. At IIM Ahmedabad, he worked on operations management as well as on management of health, population and nutrition programs. He has several publications to his credit, including his co-edited book titled Innovations in Maternal Health, Case Study from India. We welcome you on stage, sir.
Furthermore, our session is graced by an exceptional panel of speakers, each poised to contribute their valuable expertise. First among our esteemed speaker is Dr. Nayan Pijani. Dr. Nayan Pijani is presently serving as Additional Director Family Welfare in the Department of Health and Family Welfare, Government of Gujarat. He has served in the Health Department for over 25 years. During his services, he has worked in different districts like Kheda, Ahmedabad, Panchmahal, and has worked in different positions at the state level. He believes in discipline and teamwork strategy for the success of work and successfully completed many health programs under his leadership.
We welcome you on stage, sir. Continuing this illustrious panel, we have Dr. Vikasben Desai, a distinguished public health expert offering valuable perspective on overcoming nutritional challenge. Dr. Vikasben Desai is a public health expert and a technical director at Urban Health and Climate Resilience Center, Surat. She is qualified personnel in public health, community nutrition, and reproductive and child health, and has more than 4 decades of experience. She has served as the additional director in family welfare, director in reproductive and child health for 5 years at state level, and actively participated in community level training and the state level and advocacy process. She is a member of the editorial board of textbooks on environmental epidemiology. She has several national and international publications to her credit and has designed and implemented various state-level child health programs. She is also the founder secretary of Urban Health Society of India. We welcome you on stage, ma'am.
And lastly, but certainly not the least, we are honored to have Professor Soma Shekhar Nimbalkar from Karamsad Hospital, Anand, sharing his expertise in navigating the complex landscape of healthcare and nutrition. Professor Soma Shekhar Nimbalkar is a professor of pediatrics and neonatology at Pramukh Swami Medical College, Karamsad, Gujarat. He has led the first DM course in neonatology in Gujarat. He serves as the head of Central Research Services, Charotar Arogya Mandal, and Associate Dean Research Services, Pramukh Swami Medical College, Karamsad. He is a certified trainer for various courses in academic medicine, such as the Neonatal Resuscitation Program, Golden Hour Emergency Program, Helping Babies Breathe Initiative, among others. He was awarded Fellow of the National Neonatology Forum in December 2021, India Gyani Award in 2014, James Flood Award 2012 and 2014, among others. He is also Associate Editor of International Journal of Pediatrics, Frontiers in Pediatrics.
With such an illustrious lineup, we are poised for an insightful session, dwelling deep into the realms of nutrition, challenges, and innovative solutions offered by our esteemed panelists. Now I request Dr. Somesa to address the panel.
Thank you, Bilal. It's a privilege and honor. I just thought I will say a few words about what IIPHG is doing in the area of nutritional issues, challenges, and solutions in the state of Gujarat. So today is a very important day for all of us. Just in the morning, we had Bhumi Pujan of the Center of Excellence in Nutrition here at IIPHG, which is going to come up over 22,000 plus square feet space just adjoining this premise, which is supported through the Naira Energy. More than the building, it is basically supporting the Gujarat state, not only here from Gandhinagar, but across all the 4 regions, Ahmedabad, Baroda, Surat, Rajkot, to basically efficiently address in terms of capacity building, in terms of research, deep data analytics, trainings, operational aspects, etc., developing sub-district action plan for the regional deputy directors of the state. We are supporting the Gujarat state through these different mechanisms. We are also supporting, very recently we had an MOU with the education department to support the PM Poshan Yojana, and I have requested Vinod Rao sir, who is here today as the chair, to also touch upon that during his opening remarks. We are also happy for all our funders, including Naira Energy, as well as Astral Foundation, who are supporting us in this entire endeavor. IIPHG is also active in the area of addressing stunting. And just, while we are having a chat with Vinod Rao sir, just before this session, he was asking us about the issue of stunting. So we are actually part of a stunting hub, which is a multi-country initiative led by, from India, National Institute of Nutrition and Professor Bharti Kulkarni. While she was with NIN, now currently with ICMR, she was the principal investigator, country principal investigator from India for the Stunting Hub initiative. So what a nice plethora. And we have Dr. Nayan Jani sir from the health department, and I'm sure sir continues to guide us on different aspects, be our child malnutrition treatment centers that we are running in Devbhoomi Dwarka, or our different nutritional initiative interventions that we are planning in the state. We are actively getting his guidance. Importantly, I also want to talk about one of our speakers, Dr. Somshekhar Nimbalkar Sahab, who has done excellent work in the area of predictive analysis. And I thought, and I have requested him while we were having a brief chat, that I would like him to basically talk a bit about his work on predictive modeling and how we can use the government data, particularly Poshan Tracker from the WCD department and Tecoplus data, to effectively predict which families are more likely, a risk coding mechanism by which we can predict well ahead of time which family are likely to have a malnourished child. And Professor Vikasben Desai, she is a school in herself in the area of public health nutrition. She does not need any introduction. So we are so happy to it. And Professor Satya, what a nice person to moderate the entire session. So I'll hand it over to Satya sir for the next part. Thank you.
Thank you, Somen. So this morning is nutrition morning. And I think rightly so, because nutrition is foundation of health and then of whole life. So we have our chair, co-chair, and 3 speakers. We are already a bit late, so I will start right away and request Dr. Vinod Rao to give his opening remarks. Thank you, sir. Please.
All the distinguished panelists, team IIPH, and all the distinguished invitees who have come from various parts of the country, and many of you are even from abroad. A very good morning to you all of. I had the good fortune of serving in health department for 1.5 years, and I was in charge of NRHM. Though NRHM has a very broad range of interventions, the most fulfilling experience of all the interventions have been the Kuposhan Mukt Gujarat Maha Abhiyan, which we started in 2016, 15-16. When I got an opportunity to go deep into this issue of malnutrition, it became very clear, very unambiguously clear, that the biggest problem facing this country is malnutrition. The day we understand this in its full spirit, we will realize that we are hardly doing anything to address this issue. If we compare the number of people who die due to the underlying cause of malnutrition, and that too under the immediate reason of wasting, we will realize that the strategies, the resources, and the efforts that are going into this, addressing this issue, is totally out of scale with the gravity of the issue. So jokingly I said, the efforts that is going into territorial security in this country and the efforts that is going into nutritional security of this country, if one has to compare, we will realize the disproportion. I have the good fortune of serving as Secretary School Education, and hence within my domain we started intensifying our efforts for strengthening PM Poshan. And our first MOU in this direction with IIPH took place last month. We are starting a nutrition cell within PM Poshan program in partnership with IIPH. We will be intensifying the implementation and monitoring of school health program, the Rashtriya Bal Swasthya Karyakram. And under the school health program, we will ensure that all primary, secondary, higher secondary schools, all government and private schools, school health program happens in true letter and spirit. We will integrate the database that is generated through RBSK real time with our Vidya Samiksha Kendra. Vidya Samiksha Kendra is the first of its kind initiative for real-time online monitoring. In social sectors, governance deficit is more acute than resource deficit, particularly in education. And hence we thought we should have real-time online mechanism for monitoring of everything that happens in education. and therefore Vidya Samiksha Kendra evolved over a period of last 3 to 4 years. We will now integrate Vidya Samiksha Kendra with Poshan. Honorable Prime Minister visited our Vidya Samiksha Kendra last year, and this was a very important suggestion made by Honorable PM that we should have tracking of Poshan along with Vidya Samiksha Kendra. So the cell which will be formed with partnership of IIPH will be sitting in Vidya Samiksha Kendra and ensuring this integration. Severe acute malnutrition, severe underweight, and iron deficiency anemia. These three will be our priority areas under this cell which will be created under PM Poshan. PM Poshan today acts as a saturation approach, that everybody will be provided with a fixed menu daily whenever they come to school. We now want to introduce differential approach also. What is differential approach? So under PM Poshan, if Doodh Sanjeevani Yojana, under the Doodh Sanjeevani Yojana, milk is provided, then milk is provided to every student, irrespective of the nutritional status of the student, which is okay. But we should now introduce something which is differential. What is differential? Differential is diagnostic approach to malnutrition has to happen within PM Poshan. Whether it is supplementary food or therapeutic food, that will have to be designed as per the findings of RBSK. RBSK findings should be linked with supplementary intervention and therapeutic intervention under PM Poshan. And we have to start with this year. In this budget, we have to bring this as a... And this is a new approach, because under PM Poshan, we believe that this, what we are giving to everybody, is good enough from our viewpoint, but that's not. Rest we leave to health department to intervene. No, we should now come and bring in supplementary nutrition and therapeutic nutrition into our PM Poshan program itself, and that will be a big policy move in a positive direction. Why should an adolescent girl first marry, then become pregnant, and then in the second or third trimester, when we identify pregnancy and identify severe iron deficiency, why should that be the intervening point? Why can't an adolescent girl who is spending her time, she is in our protective custody, a child in school is in our protective custody, and when that child is with us, why can't we intervene therapeutically even before the girl child marries and enters into that vulnerable stage? So I think this is something which we have to own up. I felt in Government of India and in the state, there is a ownership issue for malnutrition. Literacy is education department's responsibility. Illiteracy is also our responsibility. Nutrition is the responsibility of Women and Child Department in Government of India. Under the business allocation of business rules, nutrition comes within the responsibility of Women and Child Development Department. So it is presumed that malnutrition also would fall within the domain of Women and Child Department. But that's not true. It is the health department who has to own up malnutrition as its responsibility, primary responsibility. Still, whenever there is discourse, these debates keep coming in Government of India and in the state. Nevertheless, let us leave both of them to debate that. Let education take responsibility for malnutrition of children in school. And let us come with our own new item, our own budgetary allocations for addressing malnutrition in schools. If we require, we may even engage professional doctors at cluster level, at block level. Let us try that. We should start with a Poshan Sahayak in every school, not recruiting a new person. One of the teachers who is volunteering to do this task, to start with in bigger schools where you have more number of teachers and more number of students. So we have 15,000 schools with more than 120 students, where we have a teacher for every grade. Our mission schools of excellence selected schools selected under mission schools of excellence, 15,000 primary schools. We should have a Poshan Sahayak from among the teachers. And these 15,000 Poshan Sahayaks should be trained. And they should keep track of school health program that is happening in the school, and have line listing of severe acute malnourished children, severe underweight children, and severely iron deficient children in that school. That line listing. And for those severely acute malnourished, severely underweight, and severely iron deficient, there should be a separate round of assessment that should happen periodically. So it's not like they will also be subjected to once in a year screening. No. RBSK. There should be a catch-up round, there should be a follow-up round for these children periodically, if not once in month, at least once in 2 months, 3 months, so that the supplementary nutrition and therapeutic intervention happening for these children should be monitored. So this is a big responsibility that we are taking upon ourselves. Let us come out of the debate who will own up malnutrition. Let education own up malnutrition of students in schools. And in this budget, we are pushing this program. I would request IIPH to support us and help us take this to successful intervention. Friends, let me thank the organizers today for inviting me to this function. I believe that if as a team, implementers and knowledge partners, you are a knowledge partner, we are the policy maker and implementer. If we work as a team with the help of other experts who have come today from all over the world, we can make big changes in the coming days. Let us make a good beginning from school education this year. Once again, thanking you for inviting me. Thanks.
Thanks, Dr. Rao, for some encouraging news. Thank you. We move on. Dr. Kulkarni, you have some opening remarks.
Thank you very much for the opportunity. I will not take a lot of time because we are running behind schedule, but I am really excited and looking forward to this discussion, because we know that for nutrition we have a lot of programs on paper, but implementation remains a challenge. We have 6x6x6 strategy under Anemia Mukt Bharat program, but when we go to ground, it's only the pregnant women who approach healthcare system, get the intervention. All other things are just in the program document but not implement. So it is very important to understand how our knowledge is translated into practice and it benefits people. And ICMR has a very big agenda on promoting implementation research. And I really look forward to the discussion on what are the implementation challenges from people who are working here, and what insights, which data modeling can show us, and also Dr. Desai's experiences of long time, like how, what are the way forward for improving nutrition in this country. So without taking further time, I would thank all the speakers and giving me this opportunity.
Thank you. So we now move to our speakers. We have 3 speakers, and according to schedule, every speaker has 7 minutes. So we begin with Dr. Jani. Please, sir.
So, good morning to all. Respected Dr. Rao sir, Vikas madam, all dignitaries on dais of the dais. Again, I will remain in time limit. But whatever Vinod Rao sir says, it is 100% true. And I am fully agree with the sir words that this is not the small challenge or small issue of nutrition. Government have strengthened so many programs, particularly in health, in education, in nutrition. In health, we have reduced IMR, MMR, whatever, and reach up to the SDG goal. But we have never focused on the nutrition, anemia, etc. This is the biggest problem we are facing at present. So many government schemes, I will not mention here, run by the health department, by the WCD, with the education support. But I will definitely say that if we see any data, NFHS data or any survey data, then malnutrition and anemia, that is always 30%, 40%, 50%, 60%. So in number if see, there are two people in the house, family, then one is either anemic, either stunted, wasted or underweight, whatever. So biggest problem as per data also, we have to take care. Again, I will thanks to IIPHG today, because this is the very important topic, and we have keep in the agenda and discuss with the forum. I will say few words for the anemia and also for the nutrition. Sir has started the program Kuposhan Mukta Gujarat Mahabhiyan. Sir, it is already still running by the department, and we are doing screening nearly 40 lakhs children 0 to 5 years every year, not up to mark, we have to reach up to 54 lakhs. So this is the program already with the initiation of the sir and health department is doing. Again, I will say from this year and with the Sada Pravesh Sosav Karyakram from June, we have also taken this program ahead. From 6 to 18 years of the children, we will do the screening for height, weight or BMI, underweight or overweight, and also for the regular hemoglobin checkup. So now we have reached up to the 18. So that is also the digital record we have created with the help of Sarva Shiksha Abhiyan portal. But after what that, right? So this is not in 0 to 18 years. You see the prevalence of anemia or in the nutrition program, all ANA or ANC care we have to take, then up to the reproductive age. So up to the 45 years we have to take care. I lastly says, everybody has to take this as a challenge, everybody. Regular height, weight, we are not doing. Wherever we go for the checkup, then we will say what is our blood pressure, what is our blood sugar. But according to our age, according to our criteria, we are physically fit or not, we are not taking regularly. Even not hemoglobin we are measuring. And everybody per se believe that I am okay. But you do your hemoglobin, then reading will say it is 9.5, it is 8.5. So problem is really there. We have to take it, and not with the support of health department or WCD or the education. Government is there. We have discussed in so many things in the Chintan Sibir. Sir is the witness of that under the Honorable CM Sir's leadership program at the Narmada Kevadia. But I believe everybody to take as a challenge, and we have to create either NGO involvement, either Jan Andolan, or either awareness campaign as a mass scale, and then we can reach up to the mark in the nutrition program. So thank you for inviting me, and I again thanks IIPHG for this is the most valuable topic we will discuss today. Thank you.
Thank you, Dr. Jani. So you can see that nutrition problem is not only WCD, health, education, but it's a whole society's problem. And I think as Dr. Kulkarni this morning pointed out, it leads us to some further diabetes, various other chronic diseases, and perhaps shaves off something from our life expectancy. So we have next speaker, Vikas Ben. Please. She has a presentation, I think it's a PowerPoint. Sure.
I'm using this presentation for my reminders of points, not for you, because I was not knowing this is going to be panel discussion. So I thought I am going to present something for a longer period. So all of you know about this NFHS data. My only concern is NFHS data is more than 50% nutrition, because nutrition is health. So first of all, we all have to accept that nutrition is health. It's not something different, and you cannot work on it on isolation. Coming to the, okay, let me say, what is our surveillance system? Every department, that means WCD, health, and education at RBSK, that is part of health, is doing surveillance. But there is no trend matching also. I don't expect that 100% data should match, 10 people here and 10 people there also, but there is no matching. From Rao sir's talk, I also can say food is some other department's job, but malnutrition is a disease which is the health department's job. So we have to accept that nutrition is our task also. So we need to focus on nutrition surveillance. We need to focus on human resource. We are getting more and more members to work for us, but what we need is members to talk in similar language, because you have to change the behavior of the community, and that happens when you give the same message to the community. What is another important thing is, this is related to WCD, that they can think of using the Anganwadi workers who are now even graduates for the breastfeeding promotion, which is coming up as a major challenge. They can be trained as a breastfeeding counselors, and they let them do the private practice. If 70%, 50% deliveries are in private sector, you need to support them for the private breastfeeding initiation also. Child feeding guidelines are almost, I'm not seeing people talking about it, but this is what I learned when I did MSc in nutrition, long back, but this is not outdated. This is something which is to be practiced, and these points are to be kept in mind. Feeding child milk, sir, is considered as a risk factor because of the hygienic problem. It may lead to diarrhea. We used to get milk powder as a donation when we started with Well Baby Clinic, which was stopped due to this. And feeding milk is also a risk, but it can be a decision of the government to do that. But we need to focus on seasonal fruit, leaf vegetables, not everything at the center. Educating mother and preparing her for that. Okay, coming to the intersectoral convergence, as it was said, Gujarat was first to start nutrition cell in health department. And madam increased the file. That is the comment which I got. Madam ne filo vadari didi. It was not to increase the file, it was to accept that it is our responsibility also. So we need to work on that, and we need 4 things minimum. One is infrastructure, second is enforcement of the program and policy, third is education of the community and our HR, and the fourth is engagement of the community. There are few points which I would like to, I'm taking little more time. I would like to draw your attention to anemia control, feeding programs, where there is lot of scope for innovation. Anemia control, we talked a lot, but it has its own issues. I would like to spend a minute for this. For first 1,000 days, there is lot of investment for child. But the mother who is supposed to take care of the child for 2 years or 5 years, special care, educating the child, sensory stimulation to the child, nutrition of the child, special nutrition for the child, her nutrition is forgotten. 60% of them are anemic, 50% of them are either obese or underweight, and we are not screening them and doing anything, having any protocol for that. So that is something which we need to focus on. Nutrition of paramedics cadre, I have already talked about. Traditional food. Millets have brought in the issues, brought in the reminder for the traditional foods. But there are traditional foods for pregnant mother and for children which we need to revive. They are not outdated. They are experience-based science. We need to convert that into laboratory-based or research-based science. Also think of geographical variation in the diet. Today morning somebody was talking about more sugar consumed in Gujarat. Maybe because that is Gujarat genes need. Okay, it's not something which has come out of fancy. So geography decides water quality, decides soil quality, decides traditional practices of food articles, and we need to also focus now on Ritucharya. With the Ayush entering into the activities, we need to learn from them. Then comes the local alliance platforms. So we have private diet consultants now in urban area. We have public health people. Everyone talks in different language, and people are confused and go for Google Drive and try to follow the diet of that. So we need a platform in every city where they sit together, they decide what will be the guidelines for our city and how will we take the nutritional profile of the people in the city. And we have started that in Surat as a Poshan Se Roshan Smart Surat Alliance. We meet every quarter and we discuss about the issues, and currently we are working on the seasonal variation of food article, and we have all members. Communication in nutrition is a major thing because it is a behavior change. One is they speak. One is they don't speak. Second is if they speak, it is not a communication. Only talking, ability to talk is not communication. And only one example I would like to quote. When we started with Mamta Abhiyan, I used to visit the centers and then I used to see nobody informs the mother what is the weight of the child and what is to be done. So I asked the worker, no message for this mother? Then she said, yes, I will give message. Barabar khawdavje. If with that message, if mother is going to feed the child properly, then that message is not required. So we need to learn. In training programs, they do excellent drama for the communication. But when it comes to practice, we don't talk. So accept the nutrition as the health challenge. And then I also would like to highlight the program which was started here in 2008, Nirogi Bal Varsh. Every department of government was supposed to be part of that. They decided one intervention every department, and then it was then monitored by this up to CM level. That somehow it is that is one of the things which I would like to talk about, that we forget about what is done in historically. You don't do anything new, as I talked about malaria, even in nutrition. You do it differently. So do it differently, but don't close down the programs which are initiated. With that, thank you.
Thank you, Vikas Ben, for giving us a quick guide into interventions for improving nutrition. Long way to go. We have our next speaker, Dr. Nimbalkar. Please, sir.
Why is this not? Excuse me. More people. Okay, fine. Right. Good morning, everyone. Many thanks to Indian Institute of Public Health for the invitation, and especially Dr. Soman Shah for considering the reason for which I've got invited. And so I'll be discussing a bit. So far, we have not discussed. This is not moving. कैसे मूव करना है? No, it is supposed to. That's what I asked him. Excuse me. Ask him to give me the screen. Yeah, thank you. I'll be discussing this particular project, and this is based on PhD work of one of my mentees who currently is in the US and working as a assistant professor in digital health. So it's a collaborative work which progressed over a substantial amount of time, over 5 to 6 years, and it got published ultimately as 3 particular papers, two in PLOS medicine, which looked at early child nutrition and cognitive achievements, and subsequently on trends in childhood undernutrition, and the main thing that we would be discussing on how we can predict malnutrition. So instead of trying to chase malnutrition or pick up malnutrition after the child has become malnourished, kind of anticipating which childs are going to get malnourished with good ability, and trying to get your resources to those children before they get malnourished. So this is something which we'll discuss. So these are all open access papers and can be found on the net, and you'll get them details including the supplementary files. So this is the map of the world, and we know that 52 million children in India who are less than 5 years have stunted growth. We have discussed this quite a bit. Now this is the map which talks about how geographically we are. But if you put this map according to the amount of malnutrition that is there, it will tell you how India is so much high in malnutrition as compared to the rest of the world. Even entire African continent also kind of dims in importance. So we have a huge problem on our hands, and unless we, look at it with understanding of what is the problem, we will not get our results. ICIES is an old program which looked at nutrition since many, many decades. And as Einstein said, if you're going to do the same thing over and over again, you can't get different results. So I think we need to have evidence-based policy making to ensure that we improve our results. So this is a way to look at it. So in 2005, NRHM was set up, and it was basically set up on some few high-focus states with poor health indicators, and this particular program was tracked for mother and child health. So around 30 evidence-based mother and child health programs or stuff related to that was kind of monitored, and programs were directed towards mothers and children, and public health infrastructure was increased, and NHM missions were, which later on became NHM missions, were set up across states. So we'll see what happened to that particular, and so our papers kind of analyze pre-NRHM and post-NRHM findings of malnutrition. And so we know, and it has been discussed, that there are different kinds of malnutrition, and if you pick a different indicator, your rates of malnutrition will change. So if you pick any one of the three and you consider it malnutrition, you will find out that malnutrition rates are really very high. So coming to the first paper where we tracked, did the trends change before and after NRHM, and did it change upon whether it was a focus state or a non-focus state, and whether socio-economic disparities, because whether you do something or not about a particular problem, because economy is changing, the problem will kind of get solved. So what is called as a counterfactual in implementation health. So unless you actually show that your intervention has changed something, just because something has dropped doesn't mean that it is your intervention which has changed something. So look, this is again looking at NFHS data over all these years, which was supported initially by USAID, and so this is the data sets that were used for analysis. So it's a basic simple time series cross-sectional analysis, and looked at undernutrition in its various formats. We looked at other potential confounders, as you can see, such as maternal age, education, and so on and so forth. And we looked at whether it was in a NRHM focused state or a NRHM non-focused state. This is the model, which I'll not go into details, but look at how UNICEF formula for average annualized rate of reduction. So that was used to find out whether having specific focus on malnutrition without any evidence-based policy making did help. Okay, so we have poured in a lot of money over many decades, and let's see what has happened. So this is your, if you can see on the screen, pre-NRHM and post-NRHM scenario. As you can see, there is a drop in stunting that has happened. So let's see if you look at average rate of reduction. So you can see the rate of reduction is slightly increased, pre-NRHM versus post-NRHM across India. But if you look at, this is for chronic, but if you look at acute malnutrition, there is a slight increase, as you can see, in post-NRHM, okay, all over India. But if you look at all put together, okay, overall, if you consider any malnutrition, there is not been a change of reduction of malnutrition since 1992. Okay, since 1992 to 2015, despite increased focus on maternal and child health and funding of NRHM, we have not achieved any great reduction in malnutrition, which we would not have achieved even if you have not funded and had NRHM, or maybe not. So let's see what happened. In the normal focus states where there was no great NRHM funding that was there was a rate of reduction of acute malnutrition by almost 2.9%. And in the high focus states, you can see it was lesser, 1.9% in acute malnutrition. So in your chronic malnutrition, in acute, there's a slight difference which is there. There is an improvement in the high focus states, but worsening in normal focus states. Okay, if you look overall, again, as we saw in the previous slide, there is no any particular change. So it kind of looks at all these particular parameters. So this is kind of setting the stage, saying that whether you increase your funding, if you don't do evidence-based policy making, or if you don't put money in the right direction, you are not going to achieve any results. So this is what kind of we have showed in this particular paper by analysis. So in summary, declining trend before NRHM continued, but at a faster rate in normal focus states, which did not get funding. Okay, and socio-economic disparities persisted. Acute undernutrition actually improved in high focus states, but this was worsened in normal focus states. And again, socio-economic disparities improved. That is because basically the economy improved and so on, nothing to do with intervention by health or education or women and child health departments. And overall nutrition that was declining before NRHM came into focus continued. So not really much change actually happened. So NRHM may have been effective in preventing undernutrition. So if NRHM funding was not there, possibly we might have had higher malnutrition than what is currently there, or we might not have had the rate of reduction. So that is one possibility. So this led us to our next particular work, which looked at, can we predict child undernutrition? So Dr. Vikas Ben was earlier saying that can we look at only children and prevent malnutrition? So the answer is actually no. It's very important that when we are talking of cognition and connection with malnutrition, most of the brain develops in utero and ex utero for the first 2 years of life. So if you don't get your nutrition within the first 2 years of life, you are unlikely to do anything much achievement. You will probably just make sure that the child reaches his normal weight or around that weight, but your cognition related issues will be lost if you don't, focus on that particular age group between 0 to 2 years. And so if you have to focus on 0 to 2 years, you need to know which kids are going to get malnourished. And that will only come if you're going to focus on newborns and find out which newborns are going to get malnourished. So this, this is the methods of the paper. Again, it's open access. I'm not going to details, but around 129,000 children with complete information were particularly analyzed. So children who had, so the various, I will not go into details, it's available for everyone. But the point was 54.4% of the children were undernourished. So when you look at NFHS data, you will find that the rates of exclusive breastfeeding are also around 54.5%, which means if your rates of exclusive breastfeeding and what happens in the neonatal period or early 6 months are not higher, you are going to land with similar malnutrition rates. So your focus needs to be on the neonatal and the post-neonatal period and track those children early on. Okay. We had around 45 variables that we considered while putting into this model, and we used 15 variables in the final model. And they had good parameters which is there on the screen for you all. And so these are the various parameters that are there. Now the interesting part is almost 10 out of these 15 parameters are collected by your MCTS tracking system, the mother and child tracking system, which most mothers would get codified or will get detected for like education and preceding birth interval, etc. But there are 5 additional indicators that we added to the model, which kind of improved the scoring of the model. So we found that this model predicts malnutrition later on in life at around 3 years of life based upon what is seen at birth. So if you use this particular model, you'll be able to kind of predict malnutrition. And why is that important? It is important because it allows you to focus resources. So when I showed you the earlier paper where we looked at normal focus states and NRHM focus states, ultimately because more money went to one particular state and not so much funding to the normal states, there was in some places it improved, in other places it worsened, and overall across India it kind of leveled off. But if your financing of that particular was based upon in which area there were higher risk children involved, so suppose you pick up Dahod and you pick up one taluka where there were more high-risk children and fund that particular taluka or that particular block, and if financing is based on how risk scores are, which area is at more risk, that would kind of allow for more better outcomes. It might be difficult, in terms of employees or resource, but at least those resources those people can be told that these kids need more attention. In this model performance, if you look at risk from lowest risk to highest risk, at 1 in 4 children were malnourished at 25% in the lowest risk, but those who have high risk parameters, according to the model, were at high risk, 4 out of 5 were malnourished at the end of. So this model kind of tells you that if you have babies with high risk parameters at birth, the 15 which was shown in the model, you are likely to pick up malnourished children much more, 80 to 90% of the time. So having an anticipatory approach rather than a reactionary approach, which is the current approach of everyone, will only improve child malnutrition. We have, because of NRHM and so many, we have had improvements in home deliveries, decrease in home deliveries, improvements in institutional birth, a lot of funding. So we have the current, infrastructure which has been digitalized. So we have the platform on which this can be run. So adding few more variables to the eMamta would definitely help improve. Now this is again a model based on cross-sectional data which has been analyzed at various points. If you want to find out whether this actually works, it would need an actual funding of a study of an RCT where we employ this model in one area and don't employ the model in another and kind of look at what is happening over a period of 2 years. In the haste to kind of do good things, generally what is happening is many policies are done which are just employed, and then after 2-3 years we do not know whether it has actually improved because of what we have done. So unless you have a implementation research based on this particular model, you will not be able to know whether it is useful or not. And so we can use it for officially allocating resources and so on and so forth. I don't know if you have used the Portion app, but it is not very easy to use, and you do not get all the parameters. And most of the problems with the Portion app are we do not have access to the data which we fund through our taxes. Okay, so pilot testing this approach, as I mentioned, is important, and based upon which areas are at high risk. And we can use decision curve analysis to optimize this model. So as this model develops, you will have immunization data, you will have complementary feeding data, you will have weight data that is inputted at 6 months, 1 year. So you can have additional parameters inputted into the model if you do an RCT over a period of 2 years. And so that is probably the next step. And unless you do that, you will not be able to pick up what is a good model to pick up children with high risk. So I think I'll stop there, and thank you all for listening to me. Thanks a lot.
Thank you. So, before you begin journey, predict what would happen and act accordingly rather than having ended up in the wrong place. So, a reminder for us on how complex the problem is. We don't have much time for questions, but I'm going to take liberty as a moderator to ask one question. And I think Dr. Kulkarni had touched upon it. Dr. Vikas Ben this morning also said something, but we have now 5 people, and this is a question from a public health professional as to what concrete and not so concrete opportunities perhaps they have, and how can they prepare themselves, because our colleagues, students here may have this question. We have told them how complex it is, how many departments are involved, how we have been doing wrong things and sometimes by mistake right things, and sometimes not knowing whether we are doing it right or wrong, and so on and so forth. And we have said that it's a public health problem. So can I request begin with our chair and then our speakers and so on, or to repeat, what opportunities are there for public health professionals and how can they better prepare themselves for it? And I think you already said in education department there may be some opportunity. So can you please briefly take that, and then I'll come to others.
So once we understand the problem, understand the intensity of the problem, gravity of the problem, urgency of the problem, extent of the problem, I think that's the beginning of working towards solution. When you are working towards solution, you need people who can support you, who can also help you better understand the problem and better understand the solutions, better understand the monitoring. So this is a sector which is a future sector. Public health is a future sector. Public health is an upcoming area where I think huge, if it's from the career growth prospects, yes, wonderful opportunity. But if in terms of contributing to the making of New India that the Honorable Prime Minister is speaking of, I think your contribution will be the most valuable contribution. Many a times we do lip service by saying health and education is the futuristic, we have to still do a lot of work. But that's just for the sake of lip service that we say. But once we start doing real work, then we will all be looking forward to people who can support our initiatives. So I think IIPH and institutions like IIPH across the country who are like sort of creating a new generation, a new cadre of qualified public health experts. I think you have a great future in terms of career opportunities. You have a great future in terms of meaningful, fruitful contribution to society.
your opportunity you have to find out yourself. Say, your joining to IIPHG was not by invitation. You decided to learn it. So you further decide to build up your career and your way to work. That is important. But do something. That is important. Try to do some innovative, which is very important. Avenues are opening up. Say previously, only health department used to accept this group. Now ICDS is also accepting this group. And it's not only government sector which is giving you opportunity. You have a lot of opportunity as now the startups and everything which is coming up. Otherwise, you should have that commitment and interest for public health, and then you can do the wonders.
There are a lot of opportunities. In fact, one of the reasons why we don't end up getting what we want is because we don't spend time in a particular field understanding it. One is like you can't really learn swimming by standing on the shore, you have to get into water. So while public health does involve interacting with people, etc., but if you pick up a particular field, say you are nutrition, I think going around with ASHA workers, sitting in cabins, finding out what is actually happening to parents, that would give you more insights than probably reading papers. And so I think you have to have both the approaches, unless you have a taste of actually what happens in the clinical setting or in the public health setting. It is not possible to get solutions. So many of the solutions will be staring you in the face, but if you don't explore the opportunities which are there, you will not be able to reach those solutions. So there is also this AI thing which is coming up. A lot of digital initiatives are there. Many of us probably don't know computer programming, but I think learning those programs, understanding what it is and how it can be applied to public health is something else which we can use of. Thank you.
No.
Definitely, public health is a very important subject, not today, but even in the past and in future also. What is changing, that is lifestyle and then way of working and living pattern. Previously, huge number of communicable diseases. Now there is an increasing trend of non-communicable diseases, hypertension, diabetes, cancer, etc. Previously, there is a difference between tribal and non-tribal. Now there is a urban and rural, right? So always there is a something new in the society, right, by the living pattern. So go ahead with changes, and also this is the most important public health cadre or the your learning. Definitely all sector need, not even government, but the private sector definitely welcome you, and partners, international partners also, they are taking care of public health. So great opportunity.
Dr. Kulkarni.
The need of public health professionals in the country are critical at this moment. When I talk of research, we have a lot of deficit in research capacity. We need people who know epidemiology. We need people who understand biostatistics. We need people who can analyze the data, do modeling exercises for forecasting. There is a critical deficit in our country in terms of people who understand health economics, who understand health system. We need strengthening of health system, and we need professionals who are experts in it. So in terms of research itself, there are critical needs where skill building is needed. In terms of program implementation, we have to have understanding of other disciplines, bring in management, because we know that operational management works very well in certain sectors, but in health, programs are are not really working to the extent they should work. So we require interdisciplinary learning, and I believe that the opportunities in public health are going to expand exponentially in coming years. Thank you.
Thank you. So I think we come nearly to the end. You can see in the country the challenges we have faced. I was trying to tell Dr. Kulkarni, when my first encounter with nutrition program was, I remember this meeting when Dr. Tandon at AIMS Delhi gave us data of 5 villages where they had pilot tested Anganwadis and how much difference did it make. And I remember now, I think this is after some 50 years, that we are now saying maybe we don't know, maybe we have to keep thinking. So, and when we look at the data, and I sort of, see income has increased, education has increased, food security has increased, sanitation has increased, almost everything is going up, but our needle on stunting is moving very slowly, half a point every year, and has to go a long way before we even catch up with some African countries. So there is a great challenge, and I think we don't know enough. So there's both challenge for learning and challenge for implementation. Dr. Rao, any final comments? No. Okay, so I think we come to the end. Thank you so much. And what's the next thing?
Thank you everyone for your valuable insights. This discussion on nutrition has been very enlightening and very enriching. Moving to the next part, I would like to request Professor Sathya sir to please felicitate our chair, Dr. Vinod Rao sir. I would also request sir to felicitate our co-chair, Dr. Bharati Kulkarni ma'am.
I request you, sir, to please felicitate Dr. Narayan P. Jani. I would also request you, sir, to please felicitate Dr. Suma Shekhar Nimbalkar. I request you, sir, to please felicitate Dr. Vikas Ben Desai, ma'am. Thank you, sir. I request Somen, sir, to please felicitate our moderator, Professor Satya. Thank you, sir.
Thank you to all the plenary members. It was very delightful to have you on the dais. Moving ahead, I would like to call upon Teams 3 for the special dance drama performance.
On female feticide.
चल जीते हैं चल तलवों के नीचे है ठंडी सी एक धरती कहती है आजा दौड़ेंगे यादों के बक्सों में जिंदा सी खुशबू है कहती है सब पीछे छोड़ेंगे उंगलियों से कल की रेत बहने दे आज और अभी में खुद को रहने दे कहता ये पल खुद से निकल जीते हैं चल जीते हैं चल जीते हैं चल एक टुकड़ा हंसी चखने एक डली जिंदगी रख ले जीते हैं चल जीते हैं चल जीते हैं चल हिचकी रुक जाने दे सिसकी थम जाने दे इस पल की ये गुजारिश है मरना क्यों जी लेना बूंदों को पी लेना तेरे ही सपनों की बारिश है पानियों को रास्ते तू बनाने दे रोशनी के पीछे खुद को जाने दे कहता ये पल खुद से निकल जीते हैं चल जीते हैं चल जीते हैं चल कहता ये पल खुद से निकल जीते हैं चल जीते हैं चल जीते हैं चल जीते हैं चल
I'm sure for all of us this act was beyond words, isn't it, guys? Thank you, team, for an artistic depiction of the real world problem of the society and giving us all the reason to act as a catalyzer and to the healthcare agents.
We have few stalls for display. There are 4 stalls: Deep Tech, Lipco Medicines, IIPHG itself, and Nayara Energy Limited stall. They are displayed there and they will be available after 3:30. I'm sure you all must be hungry after so much of information and knowledge. So now we can disperse for lunch and we'll be back here by 1:20 for the next plenary. Hope to see you soon here. Thank you. The venue for lunch is the mess or the canteen at the ground floor.